Welcome to another episode of Progress, Potential, and Possibilities, discussions with fascinating people designing a better tomorrow for all of us. I'm your host, Ira Pastor.
I have often said that there are only 4 kinds of people in the world: those who have been caregivers, those who currently are caregivers, those who will be caregivers, and those who will need caregivers.
The Rosalynn Carter Institute began in 1987. But Rosalynn Carter's connection to caregiving spanned more than 80 years and was deeply personal.
When I was 12 years old, my father became terminally ill with leukemia. I still vividly remember going to my secret hiding place, the outdoor privy, to cry.
As her perspective widened, she saw the impact of caregiving on communities and the way they support each other.
Caregiving is happening everywhere. In homes, in schools, in universities, in hospitals, in retirement villages, everywhere.
When my grandfather won the race, then she sought out to change things for the better for family caregivers.
As First Lady, Rosalynn Carter brought attention to issues typically stigmatized and hidden from view, most notably mental health. At one early meeting, as she explored how to meet the needs of her community, she realized mental health was inextricably linked with caregiving, an issue often overlooked and ignored.
It was the most emotional meeting I have ever been to. Women were crying in the audience saying, "This is the first time anybody knew how I felt."
Very quickly, the organization found that caregivers span every generation, come from differing backgrounds, and care for individuals with a wide array of conditions. What unfolded was a portfolio of much-needed programs that could be scaled to reach far beyond Georgia.
We launched Operation Family Caregiver in 2012. It empowers caregivers by teaching problem-solving and coping skills.
Caregivers can feel isolated and sometimes alone. They may feel that there's no one else like them in the world.
Even as the Institute made life better, one person at a time, Mrs. Carter continued to show up for caregivers, not only in their communities, but in the halls of Congress.
We face a national crisis in caregiving, especially for our elderly citizens.
She called on the President to create an Office of Caregiver Health within the Department of Health and Human Services.
We need more family and medical leave for caregivers. We need tax breaks for caregivers. We need more respite care.
In its efforts to ensure that family caregivers remain visible and supported, the Rosalynn Carter Institute for Caregivers carries forward Mrs. Carter's visionary leadership by acknowledging their needs, championing their rights, and always tending to their humanity.
If someone is getting into a caregiver role, it's going to be hard, it's going to be challenging, it may be the most challenging thing you ever do, but you should know that you're not alone.
RCI is one of the leading organizations that is going to take caregiving from where it is today and find the policies, the advocates, and the people to get it to where it needs to be in the future.
I had a lot of opportunities. I hope people think I took advantage of them and did the best I could with them.
Mrs. Carter started us off, but this is only the beginning. We all have a role to play in supporting the caregivers in our communities, in our neighborhoods, and across the nation.
Welcome, everybody, again to another episode of our show. Bringing you another really fascinating guest today involved in creating a better tomorrow for millions of people out there. Today on the show, we have the honor of being joined by Paurvi Bhatt, Interim CEO of the Rosalynn Carter Institute for Caregivers, an organization that is focused on driving transformative systems change to improve the strength, health, and resilience of family caregivers. Paurvi is a global healthcare executive known for creating strategies that optimize public, private, and philanthropic capital to expand equitable decisions, resources, and care outcomes in communities around the world. She's known for creating very unique solutions to bring together nonprofits, governments, companies to ultimately pilot, pivot, and scale these various healthcare and social services programs. As both a family caregiver and immigrant herself, Paurvi focuses on so-called culturally responsive solutions in the care economy, and has focused much of her early career on HIV/AIDS, women's health, and health equity worldwide. Is trained in health systems and economics, did her undergraduate degree in neuroscience at Northwestern, went on to do a master's in public health at Yale with a focus on health management and population economics, as well as doctoral work at Johns Hopkins. She's a very active spokesperson, author, podcast guest, and presenter on a range of topics, which we'll be getting into today, everything from health systems and economics, to immigrant issues, to the role of women working daughters and family caregivers, as well as women's health. A lot to get into today. Very important set of topics. Honored to have her with us. Paurvi Bhatt, thank you so much for taking time to come on the show.
Well, thank you, Ira. It's good to be here.
It's great having you. I'm really looking forward to a range of these topics. Would love to start off with you though, sort of going back to the beginning, because we're going to be sort of at the intersection of these themes in terms of, at the beginning, HIV, in terms of women's health across life stages, and of course caregiving, which we're getting a lot into. Take us back to the beginning, if you would, and a little bit of what started your journey, not just in this area, but in some of the organizations you're involved in, from USAID to CARE to the Global Health Council, thinking sort of globally about these very important issues. Please.
Well, thank you, Ira. Yes, you did reach back, and it's important to go to the beginning, so I'm going to really go to the beginning. I was in between my freshman and sophomore year of college. I had the opportunity to work with the Missionaries of Charity in Kolkata, India. It's Mother Teresa's organization. And I start there because at that time, my aspirations were to be a physician. And candidly, as a 19-year-old, my aspiration was to meet her. And when I landed in Calcutta, and I got to the office, so to speak, back in the day, they'd have the in and out board. And from a certain generation, you remember that's how you would notify if you were here or not. And as soon as I got to the door, it said "Mother out." And that very day, she left to come to New York. So I did not spend the summer with her. And because of that, I learned one of the most important lessons that I imagine she would have wanted me to learn, that it was never about her, it was about the work. And so very quickly I had to pivot. And the sisters put me at first for taking care of those that are destitute and dying, at the bedside of people that were in their final hours. That was very difficult for me. And then they moved me to an orphanage, and that's how the summer began. I came back and was working in a lab at the University of Minnesota during the summer, and started to realize I don't know that I can do one-on-one care, just the emotion of that, and was introduced to the idea of public health. And that was early days, so I was not aware. It was still very early in the HIV time, if at all. So a lot of our understanding as a general population about public health was very different. But that got me started. And I think that's very important, because we all know how the story ends with me now leading an organization about caregiving. But that is where it begins. And so from that, went on to my education, and ended up working with the U.S. General Accountability Office. And one of my first assignments was to look at the flow of resources and policy promises made first in family planning, and then in the global HIV response. So if you know USGAO, it has a real reputation on facts first, and really follow what the decisions with the promise and the money actually was intended to do. And that's where my training began. And I was one of among the first folks to actually write some of these first reports from GAO on what was happening with HIV. And that set the stage for a lot of just how to look at a lot of these issues that are deeply personal, that may not have a real solution, but how to better understand with objectivity, how are people thinking about it? And then are we really doing with integrity what we said we would do? With that in mind, I knew I was young, and who was I to be evaluating things when I never did the things? And so I stepped into trying to figure out how do I do the things, and ultimately ended up working with CARE, one of the largest nonprofits that is focusing on global issues. And in that time, HIV at that time still didn't have therapy identified. So it was early still, but it was part of the global AIDS response, and I was leading AIDS work, and then eventually was deputy director for health for them. But during that time, it became very clear that a lot of what people were doing were taking care of people during working that were working age, being brought home because they weren't able to work anymore, especially in parts of the world that didn't have ready access to health services, which meant kids needed to come home from school because either they couldn't afford to continue to send them to school, or someone needed to be home.
Yep.
Or grandparents needed to come back because people needed to be taken care of at home. So I'm just going to pause on that. That was one of my first experiences that connects, right, to the missionaries of charity. And what are we all facing right now, except somebody's at home that needs care. And that was the same beginning for many of us from that time. Moving from that very quickly, because there weren't a lot of people that had some of those early experiences in that pandemic, that we all ended up getting involved in a variety of sectors and advising in a variety of ways. Ended up at USAID to lift up the economic impact of HIV more broadly on economies, but the microeconomy, what's happening at the household, why are these decisions being made, and what's the role of the health system now in doing something. And that quickly led to industry getting involved. And if it is a part of our larger cultural evolution over that time for our generation of how quickly companies got involved. I'm biased, but I'll say it's one of the first major social issues that required cross-sectoral participation. It was required because advocacy had to happen, and it did. And we owe a lot to a community that worked very hard based on their own responses, their own needs and vulnerability, which is the LGBTQI community that needed to get involved and for survival. And they're alongside with us even today with every social response that happens. But at that time, it kick-started what's the role of companies?
Right.
And I was a part of the Abbott response to ensure that drug pricing dropped and that we used philanthropic arms as well as business to be able to improve access in responsible ways. And then different administrations started to get involved. And finally, there was a therapy that interrupted mother-to-child transmission of HIV, which meant now absolutely industry had to get involved. And even if you happen to make an HIV test, if you didn't know you were positive, how could you interrupt the pathway from mom to child? And so there was a lot of collaboration that started to pick up speed. But then it was clear, well, employees, do they have what they need? And Levi Strauss, which was the first company to respond to HIV from a workplace view, based in San Francisco, for a variety of reasons, just hadn't had the opportunity to catch up on providing therapy. And what was that about? But employee benefits. And how do we ensure that employees have access to everything they need based on the health plans that we offer them? And so based on a Clinton Global Initiative commitment that company made, I joined to help shape employee benefits to make sure some of these unseen health issues that people are facing are actually part of the larger benefit package that is necessary. And then that moved on to non-communicable diseases and Medtronic, where I had an opportunity now to continue that type of work of larger inclusion. But medical technology in particular hadn't yet had the opportunity to expand as quickly as pharma. Because when you think about it, what do you need for a medical technology? You need to have a certain level of healthcare expertise that's resident in every part of the world. If you're inputting a pacemaker, you need to have a surgical cardiologist around. There's a lot of things that are about the capacity of the health system that are necessary to be able to get to access. So that pairing of what do you need from a skill set, the resources, and then the intent to really go global. Once again, just like at Abbott, it required putting together philanthropic resources, people, and in pricing and intent My role there specifically was around the philanthropic and assets, and the way that we could get our cash assets to where they needed to be in partnership. And the whole arc across all of this story is that the partners closest to the people who are at home who need care are the ones that need the resourcing and hardwiring inside of the reimbursement system, so that we're fueling those community organizations to be able to be at home together with the people that are at home who need care.
Mm-hmm.
And
Mm-hmm.
in that whole pathway was my own care journey, that I didn't even notice or see until Mrs. Carter and I had a conversation a few years ago. So my trajectory is really tied to the global health pathway across different sectors in different countries, and really paid out because of my immigrant parents who came. My dad came as an engineer when this country needed engineers in the early 60s. And many of us felt the moral responsibility of the brain drain that created for the country that they left. And that was partly what put me in the beginning of that story of going back to India when I was a teenager.
And, in the period, before you get to, what I'll call sort of your big corporate social responsibility work, something happens there that I want you to talk a little bit about, because I think it's an extremely part of your sort of the sub arc of your overall arc. But 1998, your personal caregiving journey begins, and you're only 28 years old at the time. Your father is diagnosed with not just dementia, but early onset dementia at age 58, which is, another thing probably we don't talk as much about, but is something that we should hear a little bit more about in sort of the overall dementia story. But can you talk a little bit about some of your learnings during that period? Because clearly, you're 28. This is not something, probably you expected, but this falls into your lap as a role. And I'd love to just hear a little bit about this as well.
Thank you. Thank you for honoring my father. His name is Harshad Bhatt. And my mother's name is Rekha Bhatt. And just to give a bit of context, I'm an only child, which I didn't introduce myself as. And the reason why is because my mother had cervical cancer when I was 3. And at that time in the 60s, the medical response to that was a full hysterectomy, which meant my father was my caregiver at that time. I'm only now recognizing it. And if anyone's been a caregiver of someone with dementia or Alzheimer's, you know that your journey of really piecing together what happened will last a lifetime, because you're mourning them at different points for different reasons. And so I'm only this year really focusing on what was happening then. And while my mom was so sick, and I was 3, it was important. And in our culture at that time, again, my parents, we didn't have other family in this country when they came. And at that time, it was the uncles and aunties, quote unquote, the family friends, the other immigrants in our community that would help take care of each other. And they put a lot of pressure on my father to say, well, let us take care of her for 6 months while you continue working, take care of your wife. And when things settle down, take your daughter back. And my dad pushed back on that and said no. So with public transportation as his only path in Chicago, he would get me ready in the morning, take me to an uncle and auntie's house, quote unquote, go check on my mom, get to work, and reverse that every day for months. And that was what set forth the closeness of our relationship. I have to start there, because to appreciate what happens when he becomes 58 and I'm 28 is to understand that whole time from the time I'm 3 until I'm into my 20s is this very deep and close relationship, because we were always preparing for my mom's illnesses, right? And he and I could be the buddies through life. Yeah. And so here I am at 28, and if you piece it together, I think I'm probably at CARE at that time, or at USAID at that time. So it tells you that I'm jet setting around and really at the precipice of my career now, and having my own voice. And in the background, we were noticing that he was known for his jovial nature, but we were noticing it was getting a bit out of control. And again, as first generation immigrants, my parents didn't see their parents every day age in front of them, which meant I also didn't see my parents take care of people who are aging, which means their cohort also, those uncles and aunties also didn't see the same. And here was something that was happening early at 58. And I'm 58 now, so this is very poignant to me. I can imagine it differently now. And so none of us really knew what was happening. And candidly, I think societally we weren't right quite ready to appreciate what was happening with Alzheimer's and dementia in the late 90s yet either. It wasn't as mainstream as it is now. So what was going on for me was just a lot of, I got to figure out how to get home and help them figure things out. I have to now make some decisions, most of which I don't even think I consciously was doing, but I was recognizing culturally and in our family, and as an only child daughter, that there were trade-offs that I was not willing to make, which meant figuring out how to create time that would involve in-laws one day when I have two ill parents. That might involve taking care of a husband, children, partner, other things when I have so much that I need to take care of here. And so I opted out of a lot of things and decisions that many young people in their 20s and early 30s make, and ended up really focusing on ensuring my family, which was my parents and I, had what we needed. That meant no overseas assignments from a work perspective, needed to stay home in a global career, and navigated all of that somehow. And somehow the condition of my dad's situation allowed me, it narrowed the universe of what I could decide, and that actually allowed me to accelerate. So from a career view, was able to do that. Personally, though, it was a lot of jumping around. I had strength from my mom, lo and behold. She was the lead in this one. And she said, you need to keep moving. And so I was an out-of-town caregiver at that time. Many of us can relate to that now. Of course, back then, did we have Ring cameras voyeuring on our parents when we needed? No. Did we have cell phones? Barely. At that time, probably not at all. And so we had to just allow for trust and staying in touch as best we could, but still continuing to come back when we could. My friends became my family very quickly. They all understood that this was going on. The uncles and aunties step in again, but now for a different reason. And eventually when they weren't able to fully appreciate and understand, and now I'll get into the dementia part of the story of what was really going on and what that would mean. We had a difficult time whether, we were comfortable going to temple or not, whether the normal kind of social calendar of the dinner parties that different families would host every Saturday or Friday night, whether my parents were included or not, because there wasn't understanding of what was happening, even for our family and how to navigate it. When it was time to get treatment, my mom, I live in Minnesota now. They were living in Minnesota then. I grew up here. She knew that by volunteering at the Alzheimer's Association, she would at least get more information. She ultimately was working in the health system as a medical records clerk, so she paid attention. She also knew that if you did the Alzheimer's walk in the Mall of America and you got yourself to the front of the line, all the luminaries were there. So she did that with my dad. And she chit-chatted with everybody. And now there you are. I mean, you're walking for a while together. And she found the lead researcher at Mayo, Dr. Notman. And in that chit-chat, she got my dad into a clinical trial at Mayo. And so that then brought me back in, and with a routine of going back to Rochester and ensuring my dad got the care he needed. This way of getting care, honestly, if you fast forward today, is still what we all need to do. My mom, as a caregiver, had to sort it out and find a way to get to the right person. And I didn't know enough about my own health system then, right? I was busy advising health systems around the world, and I couldn't help as much as I could here. Finally, I'll say that my mother's cancer has picked up time, so she enters the story in this period of time as well. And, I needed to learn about FMLA because friends needed to help me understand what it was. I didn't. Even as I was interviewing for jobs, when cell phones were finally there, I would bring my cell phone into the interview. And while other people had theirs on their desk during the conversation, I would take that moment to say, yours is likely on your desk because your kid might fall at a soccer pitch or something. Mine is here because my dad may wander. And both of us are going to need to step away. I am stunned when I look back that I even had the tenacity to ask, but I just figured if they knew the truth from the start, that if they chose to hire me, they knew what we were all in for, as being able to do this. So those were some of the wrinkles in all of it. In the end, we did have to make that hard decision many families have to make about memory care. And again, that was a very difficult one culturally for us, because that is not something that any family really wants to have to do. But when you have to do it, there's different levels of appreciation and understanding of it. And we were among the first that had to do it in our community. So that started another round. His long journey ended at 75.
I appreciate you sharing that part of the story, and I'll get to your mother in a minute, but I want to ask you about one other thing in the meantime, because it's I think it's kind of important, again, as part of your journey, because you mentioned, when you got into sort of I call the big corporate social responsibility place, and you're doing the work at Abbott on HIV and Levi Strauss. You talk about the transition to Medtronic and sort of the non-communicable stuff, and I was looking at some of your papers from then, where you're talking about sort of, because you didn't just look at the U.S. You were looking at you were in Brazil, you were in India, you were in South Africa, this interesting Health Rise program. And I thought there's kind of interesting parallels, because I had folks on from like the Merck for Mothers program, a GE Foundation, a lot of women's health there, and there's always this, they're talking about, we're dealing with this issue in Nigeria and Bangladesh, and we got this horrible situation in the United States. I'm like, United States? What's with the maternal mortality here? And sometimes we forget about just some of the homegrown numbers. And I just love to your perspective when at Medtronic, again, major med tech company, thinking about these issues, hypertension, diabetes, clearly a very hot topic nowadays, all things Ozempic and all that bit, but we got problems per the social determinants, per various sort of health systems, capacity issues. Talk a little bit about that as well, because I think that's another important piece here I don't want to gloss over on your journey. And if you could say a few words maybe about that, I think it's kind of an important piece here.
Sure. And I can comment a bit about what was happening at that time. Of course, every company's moved on and there's plenty going on, and it's worth reaching out to any one of these companies today, because to your point about even the evolution of the technologies that are there in pharma that's there today is very different from when we were responding. But I think it's important to note that at that time, and in each one of these moments that I had the privilege to join, it was when the movement for that disease set or part of the health system required an opportunity to leapfrog. There was no other way. And so when you come to non-communicable diseases and you rewind back to that time, you'll note that it was right when things were, I think it was among the first times that there were resolutions in the WHO for non-communicable diseases. Fast forward to today, the WHO had another resolution for NCDs and added mental health now. So you can see how it's now evolving from what it once was. But in that time, when companies like Medtronic and others were really stepping into the global space, it was really facing the conundrum of some of the solutions that were there were these technologies that required a lot more than the pathway that may have already been cut by pharma for some of the other issues that were being addressed. Mm-hmm. So if you're not direct to consumer with a pharma product, but you really need the help of the strength of an acute care system, what would that take if you're trying to reach rural Kenya, right? Which is, and understanding that you have just an authenticity alone, you have to face what is happening then in rural Minnesota, rural Georgia, or any place else. Right? Do we have what we need here? And I was very proud because it also opened my eyes, after doing so much in every other place except my own. Like I said, I didn't even understand my own health. I still don't. Let me just be clear. I think none of us fully do. That's why we're here. But but if you're trained in it and you are sitting in the seat and you are professionally here, it's our moral responsibility now to say that and try to correct for it, that misunderstanding. So in this instance, Medtronic, I'm very proud of what they said. They said global means the US. It never didn't mean the US. So if that's the case, what do we need to do? And in the work that was happening at that time, we did have a program called Health Rise. I think every alumni of that program still remains very, very proud. We really took a look at, well, how do we work on the kinds of partnerships we may all be very schooled in doing in the global health space, which are agreements that are happening with the ministries of health, with the local level, provincial levels of health, with the clinic on the ground. You can see it in your mind if you have been doing this work globally. Well, how does that actually work when you're in the United States? And it became very clear, well, yes, the Department of Health of, we chose a few states in the US of whether it's in California or in Minnesota, of course, where we were operationally headquartered at the time. What does that agreement look like? And what's the best that any company can do in its social response is to galvanize a greater response, to use seed capital, start to take a look at what's possible, get comfortable and help others get comfortable with crafting a new pathway, and then doing the best you can to figure out how to grow this response and put yourself in the right place in it, right? And understand the difference of what corporate philanthropy is and what a 501c3 foundation of a company is and what the edges of that allow and what the company itself allows and what the branding of that may mean. And that's where the movement of CSR, ESG picks up speed, right?
Yep.
My role in that in the beginning days was to create those CSRs and to get going. And when now it's exactly, when I say now over the last 10 years, it's exactly positioned where it is intended to be, the integration of all of these issues. But at that time was something else. So for the NCD category, for what was happening for companies like Medtronic and others, it was really to now break into that next evolution of what healthcare could be and to strengthen those systems around the world, but not forgetting here, because so much of the research happened here and so much of the care happened here. And what did that allow? It allowed the acceleration of what we could do here too at the same time without it being stepwise and then coming back and taking a look at what is needed here. And when I bring that back to what's happening even with caregiving today and for caregivers today and the importance of the rural health issue in any country in the world is what do we do? And that takes me back to what I was doing in rural Thailand for the early days of HIV. And what was that? It was kids couldn't go to school and they had to come home because there wasn't anything except for them and maybe a health worker, a community health worker that could be there. Well, lo and behold, we have community health workers in the United States too. And what are they doing? The same thing. They're helping to bring community perspective and health expertise closest to the doorstep with people who may not get what they need. And they run alongside the health system. And if in the best circumstances, they're integrated in it. And connecting all of these dots so that the pathway of care is fully integrated is what we're all striving for. It's this chapter now when we're realizing, well, that means each of us too. And actually that entire system is relying on each of us. And that became clear in my own story, but even in really listening to what was happening at the bedside of the cardiac patient who just had a pacemaker and is now discharged to come home. Who's at the bedside in the hospital and who needs to be at the bedside is home ready. It was never ready. It's still not ready. And who is the biggest part of that link? It's each of us in the roles we play for the people who need us in our private lives. And now it's really, we're creaking under the pressure of that. And that's what's now in our lane. So that particular piece of it, the non-communicable disease piece of it, has known this for a while, like we all have, but now it's because of its closeness to the acute care system where discharge is happening all the time. And now how do we galvanize that knowledge and awareness and formalize it so that we can all be supported is what the next chapter of this is.
And one more thing I want to just talk about before we get to the Rosalynn Carter Center. It's like I contacted you actually several years ago when I first wanted to have you on the show, Paurvi, and I started getting these autoresponder emails, but I have some in my email system still. I look back and basically they say something like, I have stepped aside from my role for the most important work of my life. And this had to do with the care of your mother because her cancer comes back. And it's, I told you before the show, I've not dealt with dementia in our family, but I have dealt with cancer. And I tell the story on the show a lot about my father and my father-in-law, who were both diagnosed with metastatic prostate cancer 40 years apart. And while in those 40 years, biotech at pharma has done amazing work in the drugs and all that, but caregiving was the exact same thing. And when it came to palliative and hospice and dealing with cachexia and pain, nothing had changed. It was all the exact same caregiving process for me and my family. Say a few words about your mother and a little bit of sort of your learning on the cancer side here, because again, non-communicable disease, obviously different type of caregiving, let's say, than dementia care, but equally trying on a person's soul. Please.
Very much so. First of all, thank you for sharing that. You just made it easier for a lot of people in sharing it. So thank you for sharing it and for remembering that time of the out of office message. So, which I was inspired to do because of Mrs. Carter. So when we get to that part of the story, we'll come back to why those messages were that important. So my mom's cancer picks up actually when I was at Levi's, and after we made some hard decisions for my dad, and then I started to settle into, okay, both of my parents are sick, and one round of her cancer actually happened prior to that, when she was only given 18 months to live. And I needed to make some decisions in that period of time. And she defeated all the odds. And she put herself through some unspeakable kinds of therapy for that. And why? Because of me and because of my dad. He was still alive. And that's the spirit of, and I'm biased, of course, she's my mom, but that's the spirit of a mom. And so she lived that as far as she could. And so when it picks up again, and it was clear after my dad's passing that we needed to put ourselves in a place, physically in a place where we would have support around us, because it was just me and mom. And me parachuting back and forth to California when I was at Levi's was just not going to be sustainable. And because I grew up in the Twin Cities and my parents had moved to Chicago along the way because we needed more understandable care. And the people those uncles and aunties that took care of us and when I was little were the ones that were based in Chicago. So they had a vested interest in understanding what that meant. So that brought us to Chicago when dad's dementia was picking up speed. So I needed to fill in that part. It's a part of this why mom. And then it was time to come back. And we scattered my dad's ashes both in Chicago and in the Twin Cities where our best years were, because he was an executive here in the Twin Cities for a company called Control Data. And for Litton Microwave, he was known for being among the engineers that figured out how to mass produce the microwave oven. So when it was time to come back, within the time I sat down here for his memorial in the Twin Cities, my predecessor at Medtronic, who I knew from the AIDS movement, so we have all found ourselves everywhere, Jacob Gale, he came to me and he says, you need to join me here. And I said, no way am I coming back to, like any good 18-year-old. I'm like, when I left, I left. So when I came back, I'm like, I'm not coming back to the Twin Cities. And within months, I was here. And that was for my mom, so that the two of us could be together. She knew people here too. And that started a journey of where she joined me, much as she joined my dad. She was my +1 to everything that was happening in my professional life at Medtronic. That was important because I'd learned the lesson of your friends and the community that you build, including at work, become the ones that are with you when things get hard. I didn't do out of office messages during my global health years before Medtronic because I didn't even think to do that. But that community of friends and colleagues who became lifelong friends were the ones that were there, including those managers that cleared the way because it took that. And so at Medtronic, when we were here, things were calm for a while. And she joined me everywhere on my trips if I could bring her. And she knew everyone all the way up to the CEO, and she became the elder that joined along. At that time, it was the Omar Ishraq generation of when he was CEO. And my dad was a GE engineer, so he's part of a GE story in all of this too. And so all of that brought us close. And my mom, of all people, knew how to do that. So when it was time, and we moved here, she brought something forward, which, because I was struggling to reintegrate, it was difficult. I mean, to come home and how to do that in Minnesota after being everywhere else. And she said, you need to bring them home. And I'm like, oh, I don't know how I'm going to bring them home. I don't want them in my house. She said, don't you think that's what they feel? And so she created our Diwali open house. Diwali in Hinduism is the celebration of light overcoming darkness. I think it's part of many traditions. As the days get shorter, we can all hope and know that the light is coming, right? And you wish for that light. And the new year comes in that time, all of the things. And so she said, well, Diwali is important, invite them over. And that began an annual homecoming for so many people. But everyone from the CEO to my team to the community here to the former mayor of Minnesota or Minneapolis showed up at these open houses, not because of me, but because of her. And they came to pay respect, spend time together. But it was also her way of saying, we got to build this community. So when her condition got worse, and it was picking up, and it was around the pandemic, and it was incrementally getting worse. I'll say when the pandemic hit and we all saw the media, and we were all, I certainly was paying attention to how many people were running to assisted livings and nursing homes trying to get their parents out or the grandparents out. It was the first time I felt the blessing of, thank goodness we're together and I'm not doing that. For all of the times I felt the inconvenience sometimes of that, it was a blessing. As things escalated, though, what it took for me to even see what was going on was that community again. My former boss at that time, the head of HR, signaling for me, do you know what you need to do next? And I said, I'm not sure. I think there's these things. She goes, have you talked to our chief medical officer? I said, why would I do that? It's like, we all do that. You have to use the people that are here, right? To help connect the dots of what you need to do. When it was time for me to take leave, again, it was a friend and colleague who very gently, but really astutely said, Paurvi, if you were to have children, how many would you have had? She called me because my mom had fallen, and I know, I didn't know the crisis of the fall until it happened and everyone else gasped. I'm like, what are they doing? We've been through so much. I mean, she fell, right? That's how I was feeling. She called and said, if you had had children, how many? I said, well, 2 at least. I would never put another kid through this. And she said, okay, so this is how this goes. Overall, the workplace now owes you at least 2 maternity leaves. Take them. And I was like, huh. And because she knew justice was my thing, right? Figuring it out for everybody else for my entire career and figuring this out is the thing. I started to figure it out. And I had help along the way to do it. Things continue to get worse, and I needed the help of other people because, as I mentioned, I didn't see my grandparents get older in front of me. My parents didn't see their parents get older in front of them. I never experienced palliative care or hospice or any of those things. My father passed away very suddenly and was in assisted living. So with my mom, I had to have other people, even though I could intellectually tell you about those moments. But now here we are back to what it was like in Calcutta at the bedside of the dying, and the reason why I didn't go into medicine. And so I had to understand that here, and then did, but also with my business acumen now, and with my advocacy in a different place now, and with every round of folks, and that same leader who said, did you talk to our medical officer? She was the one who said, stay in palliative care as long as you can. They're going to ask you not to, don't listen, because of her own experience. And I did. Was the most important time together that we had was with palliative care in the home. And just the emotion of even that team with us. And when it was time for hospice and people were coming through, this is where the cultural part became very clear. All sorts of offerings that were being said, use of the word chaplain, which is it's unintended, but separates so many of us because, and my dad was very direct about it in hospital stays, or he'd be like, not needed. Our ancestors have had this conversation before. I'm like, Dad, you can't say that. But because of the word, right? And so it is just change the word, right? It's something we all want, is that comfort. And so have become much more vocal about that. During my mom's time, she would be even things like Medicare Advantage on discharge when you're brought food home, right? The variety of vendors that would offer, 10 days worth of meals home. When I would look at the menu at the first round, there were no vegetarian offerings. So here I thought, great, this is helping me as a caregiver. And then the only thing that we had was oatmeal. I had 10 days worth of oatmeal sent home. Sitting in our garage in Minnesota, which was fine. It was cold, but the offerings weren't set up to be available for all of us. And in the hospice realm as well, I was really clear. I'm like, do you know how many Hindu temples are in the Twin Cities? And there was silence. And I said, here, we're not here yet, but I'm just going to say when it's time, it's not like we're at an Indian restaurant and I'm helping you with the menu at that time. You have to know more than I do to help me with the menu. So back to even that example from Medtronic, or when you were talking about what does it take, even in the US, it is the community partnership that's the closest to the household who knows, to be able to be now mainstreamed inside of the larger system that's trying its very best. The intention is absolutely right. Something is getting lost in the execution, and that something is the awareness that it's going to need to adjust and adapt. What we're offering won't scale until we do, right? And that became very clear in this time when I needed help in helping my mom, but I couldn't help myself, but just to understand this part now from an economics and a business lens. And then now in connecting dots for what all of us need, because when you go into anyone's home, by definition, you're in someone else's culture. You don't have to be from another part of the world. You're just, even if you're next door, it's different. And so that awareness and how to settle into it can be systematic, can be addressed as a system. There's a systematic way of addressing it. Mm-hmm. It just requires an intention again, as we've been saying all along. Eventually, my mom does pass. All of those people were a part of that journey, even though we were in a different stage of the pandemic. The pandemic was very real. She had over 300 people in her memorial, and most of them came from parts of her history here in the Twin Cities, which is why I brought us back here, my dad's history, but generations of the Indian community here who never met them, and the Medtronic crowd who were there with me and all of those folks along the way. Our home was filled with flowers, and people know my mom because of those Diwali parties. And now this house is crowded because I continue them because it was the right thing. When you're feeling alone, you have to bring people together. You have to take the first step, is what she said. And that is hard, as anybody knows, is that you just wish someone else would. And so it's a blended message. But she did instill that in me because I'm an only child. And so you have to. And so it does bring us back quite a bit of this whole journey, including my choice not to go to not continue my PhD was because of my dad's illness at 28. I had to stop, right? All of those things are part of my mom's choices in not continuing or not being able to finish school or do well in school or be able to stay fully in class because she was taking care of my grandmother who had TB. And that generational handoff is very clear if we take the time to ask, but we can't just accept that that's just what daughters do or that's just what sons do. Right. We're at a place now where we can't. And if you happen to be a daughter or son who's doing it, there's no pathway in the workplace for working daughters and sons. There are for working dads and moms. Right. So what are we going to do from that view? But also if you happen to be in health and or care, is the weekend struggle that we're facing part of our Monday morning decision making? And if it's not, maybe we need to pause. Kind of like how you started with even your own discussion of how you've been a caregiver and understanding what's happened. Yep. Right? It's changing the color of how you choose to have these conversations. It's now changing the way I would make a decision. And I would just argue it's got to change the way we all make our decisions. Now, things won't change if we don't bring them together. Absolutely. Which is Mrs. Carter's story. It's entirely her story.
Well, yeah, let's go there now because okay, so we just had a nice 3/4 of an hour introduction, which is great. But now let's get into the current organization because probably as you're talking, you're describing, and I'm stealing obviously off the website. You're describing a caregiving system that is fragmented, that is inaccessible, that in many cases is non-existent. 100+ million family caregivers in the U.S., as you and I are talking right now, providing some type of compassionate care. And as we just had Deb Whitman on from AARP a couple weeks ago, this is not a small number. This is close to $750 billion of unpaid activities. So major economic impact. Introduce Rosalynn Carter Institute for Caregivers, your current responsibilities. I guess your first meeting with Ms. Carter. Take us into the organization.
Oh, well, it's an honor to introduce this organization and to bring it to everyone's attention, especially in this important time when we're all going through so much transition in our lives, as well as where our organization is also going. So the Rosalynn Carter Institute for Caregivers, it began nearly 40 years ago. So let's also pause on that. The insight of recognizing that family caregivers require focus. Mrs. Carter's focus areas have been family caregivers and mental health. So I'm bringing both of these into this conversation just to pause for a second of her insight in recognizing that these issues are the ones that are very unseen. And we'll carry on with the caregiver part in particular. But when you fast forward to today, what are the two biggest issues of our time? How are we going to take care of each other? How did we value it? And what's happening with mental health in any country in our own neighborhood. So those two things are where she began. And why she begins is because at the age of 12, she's also become a family caregiver. She's making trade-offs early on in her life. She's in a small rural community that we all know now very well in Plains, where that story unfolds within her family and across the community. And she sees and is also impacted by the trade-offs that are happening, whether it's in schooling, whether it's in how she's engaging as a young woman in her life, all the way through to when I do meet her, and I'll get to our conversation, but even when she introduced many of us, and there were convenings that RCI would host. We just did one last year as well that brought caregivers and thought leaders together. And at the time when she was able to join us, she would speak, and she even giggled then. I think President Carter was on one of his rounds of cancer at that time, and said, "See, here I am still. I'm still doing it."
Yep.
So she really humanized so much, but beyond that, really helped everyone recognize that this is a part of our lives, but it's also part of our responsibility and a part of our opportunity to see each other, hear each other, and then start to do the things that allow us to support each other and help others support us. And for the Institute, which was embedded in a university locally as well in Sumter County, Georgia Southwestern University, where President Carter and Mrs. Carter also went. She also recognized that trade-offs are happening for students. Like I mentioned, I dropped out for my PhD. She recognized that there were caregivers who make this trade-off. And with all of those connections in place, the Institute was born there and then became independent more recently, and has been very focused on as mission, based on her mission for all of us to see, hear, and support family caregivers. And family caregivers are the ones that are being very specific about this, supporting those who are experiencing an illness, who are experiencing the arc of aging, and or experiencing a disability. And what that may mean for those of us who step in to take care of those in need of us. And that could be a neighbor, that could be somebody in family, however defined. And seeing us means that we're doing a lot of this work, as you mentioned, in terms of what's the unvalued amount of labor that's happening. The Institute in its beginning days really began in shaping training and education and ways of really listening to what our families needing, and then figuring out what would be most supportive for them. The process of just being heard is such an important part of feeling, that you've got a community around you. But beyond that, is there something more that will help you feel more confident in the care that you may be providing at home? Is there something more that will help you ask for the things that you need? Is there something more that we could do within the health system or within churches or anything else that help educate not only all of us to be better caregivers, but the community around us to understand what these issues are? And over time, it's evolved, of course, because of who the Carters were and who Mrs. Carter in particular was, in recognizing that they had and wanted to make sure that the unseen issues that they chose were seen by many to get to scale as far as possible. So that grew out of home, which they both so deeply believed in and went back to, but then became into influence. Like, how can we scale what we do? So what were the big things that we needed to think about? And we recognized in listening to caregivers a couple of really big examples. What are the places where people come together to get care? Churches, of course, right? And temples and the rest. And how can we engage? So there were partnerships that began that allowed for dementia education through those avenues. We recognize that a big thing that goes unseen is when there's a natural disaster. Look, we're in this, I mean, I was going to say we're entering the season now, but if you were really honest about it, the last 2 years, every season has been the season. Wildfires in Minnesota and tornadoes in California, right? It all got scrambled. So here we are. I didn't know. I sure didn't prepare for my mom when I was taking care of her at home when she was on oxygen, that what would happen if the power went out? What would happen? And so creating those tools, working deeply in partnership with FEMA, the VA, and others to make sure that family caregivers have the skills that they need. And now calling upon home health aides and others to provide that service of helping us be prepared when things are quiet so that we know. You know, I would often say I have a sticker on my window for my dog to let everybody know that I have a dog in the house, but never was there anything to identify that someone in need was here beyond that. So what do we do there? So how do we go to scale in what we know? Why FEMA? Because of the role President Carter had, of course, in creating FEMA, right? So really activating these connections. And then recognizing now more than ever that because we've been at it for as long as we have, we can say that some things work. This isn't new. We may all be seeing this as a new area because caregivers don't identify themselves as caregivers, right? That 105 million that was noted by Rand, you know, which was, you know, the next round of us knowing how many of us are caregivers. How did we get from 53 to 105? Is because the questions they asked were about the things people do, not what they call themselves. And when you ask people about, do you do these things? Then when you aggregate that up, those are the numbers of people that are actually caregivers because they're doing these things, the acts of care. So when you don't identify, you don't even realize. But when you do, and you get services to help you, we've been able to demonstrate things that training works, spending time together works, making sure that if you understand dementia, then you're able to help other people know what you need. When you have something called self-efficacy, your confidence gets stronger as a family caregiver. Now you can have the kind of conversations I had, right, with the hospice folks and the rest, because you have some agency in it. It's groups that have been around in this for decades that now have the information to, and hopefully back to leapfrog things now, inform the next chapters of things so that we can go to scale. And RCI has had a huge hand alongside AARP, alongside the National Alliance for Caregiving, alongside so many others now, because we're all here and seeing it differently, to be able to say that our job now is to ensure that we're breaking some of the hurdles that are in place and go to scale. The issue here is that it's not the same as a brand new virus.
Right.
So how we come together on this is probably the biggest challenge, because when it's a brand new virus and someone rings a bell and says we're in an emergency, as we did with COVID, as we did with HIV, you see the way financing happens, the way leadership steps in, the way advocacy happens is incredibly different. Right now, we're in the midst of how do you reshape the way we think about aging and the resources available to it? How do we reshape the way we think about philanthropy and what's always been there? How do we reshape the way we think about care? Is it really just the health system? Is it something else? You mentioned social determinants. That's become a term of art, but have we done anything? So all of this is the next chapter of what we've got to do. And RCI, you know, has called in over the years for an Office of Caregiver Health, right? Bring agencies together, bring us around the table and get to the greatest efficiency we can, because we do have resources, but we've got to make them efficient and make sure that caregivers are a part of that conversation. And I often say, and you know, why I take it so to heart to make sure that we break the compartment of, I'd say it as patients also. Each one of us has been a patient, and each one of us is somewhere in the arc of caregivers. Right. And if that's the case, then we have the responsibility to question, or is this the right decision or not? Is there something else we could be doing? Would I benefit if this happened for me when we're sitting inside of the boardroom, just as when we're sitting around the kitchen table? And that is what I learned with Mrs. Carter. And my first conversation with Mrs. Carter, and I still don't fully remember or even fully understand how I came into this universe. It just happened. And it really did. They found me. And I was vice chair of our board before I became inside of the organization in this way. And in that first conversation, I hadn't fully appreciated that I was a caregiver. And when we were talking, she said, I knew I was a working daughter. I said that often, but I never said anything about being a caregiver. She asked me questions about my mom. and my grandmother and aunties and all the rest. She asked me, why is it ABD in terms of my PhD? She knew to ask underneath. And then she looked at me and she says, you realize this is generational and you're not alone. And I said, I did not think of it that way, Mrs. Carter. She goes, that was me too. Right. And so that first conversation and that level of intentionality, I think anyone who had the privilege of meeting her would say is what happened. And anyone who delivers care, however defined, brings that kind of intentionality. And our job is now to scale that. I was on a call yesterday that was around global leadership, and someone had asked, and anyone who knew me from my past would laugh that I, of all people, would say this. I said, I think the thing that we've forgotten to do is walk our neighborhood and look at each other eyeball to eyeball. Because at the end of the day, if the out-of-town family caregiver can't get there, who's the one that's there? And it's someone who's seeing every day what's going on here. And to do this with care, not with transaction or obligation, is where this has to begin. We're in a social disconnection pandemic now, right? And that was another WHO resolution that happened that I was proud to be a part of, which is the resolution for social connection. So we're coming to a new era of, will we care for each other? How will we care for each other? Are we going to value it? And are we going to scale it? And that's what the RCI has been calling for from the beginning. But it began with the neighborhood, and we're here again with the neighborhood. And how do we get that to move forward? And that will be a part of where the next chapter goes for this work. And all of it is starting with this conversation like you and I are having, and to have the courage of that conversation, and to bring it into every room. And we're lucky, I think, as odd as it is to say lucky, that these past 5 years have allowed us to see each other more clearly. I often say, while there are many limitations to the Zoom room, the one thing that has happened, never before have we shared this much eye contact. And because of that, it makes it a little bit easier when we have these conversations, because we are now more comfortable. We have no choice but to look at you, right? And that's and so we can see, and that has a lot to do with a lot of this work as well. So the bottom line is, we began with listening. And we ensured that developed opportunities and training to help those that are trying to do their best to take care of others, have what they need, whatever that need was. It wasn't based on any particular science. It was based on really listening. And the science behind it was the data. Did anything change? And we saw that things changed. At least 25% of the things that we were focusing on, whether it be dementias, confidence, burden, getting the health system to know more. And if it was in the rural segment, it was even greater. They felt like they could actually get things sorted in the health system better, and felt more connected. And all of that came from really growing the work from within, and then leapfrogging and using the systems that we know of, whether it's emergency response, healthcare, public sector writ large, but convening, bringing everyone together to have the conversation, listen first and shape what's next, and actually look at what's happening outside of healthcare and accelerate getting those components to come together. At the end of the day, if I still don't have a ride to my clinic, what am I going to do? At the end of the day, if I don't have broadband for the telehealth someone's trying to offer me, what am I going to do? And 9 out of 10, the working daughter or son has to come home from work to get that settled. And our paid leave, I don't think, was intended to do that. It was intended so we could spend time with the people that we wanted to spend time with, not to spackle together the parts of whatever system that was supposed to do it that didn't do it. And that's the inefficiency.
You brought up the topic of the Office of Caregiver Health concept. And as you talk about on the website, this proposed model has to do with dismantling a lot of silos, and per some of these programs you were just saying, relationships with FEMA per emergency preparedness, relationships with the VA per the unique nature of military caregiving. You're bringing a lot of different folks that may not normally speak together. And I'm just interested in, if you could sort of elaborate a little more on what the Office of Caregiver Health would look like. I know, I read some of your sort of the testimony you gave before the Senate, state of Minnesota a couple of years ago, but have you been getting, I I know there's a lot of weird stuff happening in Washington right now, but have you been getting down to Washington, getting up to the Hill and starting to talk about something like this? What's the status of it in 2025?
Yeah, no, I mean, I think we're all in a moment of really recalibrating what is the best way forward. And we're joining, of course, with the voices of many others that are keeping an eye on what's happening in Washington. And what we're happy and encouraged by is the issues of caregivers are definitely a part of the dialogue. And many of the questions and issues that are coming up kind of come back to the Office of Caregiver Health, if I can come back to that, in the way it was framed at a different time. And I think we have to recognize that it was at a time when we could see that there's this opportunity, and that opportunity still exists, which is around efficiency. The silo dismantling isn't around creating something else. It's around creating the conversation, right? And ensuring that the caregiver is in the center of that conversation, the family caregiver, so that we could come up with the best solution with the resources that are available and point it in that direction. That was the intent, and I think that is still the intent for what many of these things that are happening today are intended to do. So, at the moment, we are very focused right now on the next chapter of our organization and what will be happening next there, while also lifting up that where there's evidence and we're seeing that things can improve, we're joining others in making sure that that is lifted. And just as I said earlier, there are things that are working, and we want to make sure that they are there. One of the biggest things that we've offered over this period of time is something we didn't get a chance to talk about yet, are the profiles for caregivers.
Mm-hmm.
And that is the game changer that will, whether it's inside of something called the Office of Caregiver Health, whether it's inside of an individual organization, whether it's inside of any policy agreement or financing arm, the main thing that happens with these profiles is that it is not. So when you take a step back, even in both of our descriptions of our caregiver journey, they were tied to a health issue.
Yep.
And yet we know, whether it was your father-in-law or father or my mom and dad, they were dealing with multiple issues. And I was dealing with a whole other set of things as their caregiver. So the caregiver profiles are specifically focused on the experience of the family caregiver, irrespective of the disease state of the person that they're taking care of. And the arc of that, it isn't even a journey in that it's logically one after the other. It could be multiple things happening at the same time, but allowing us to see the caregiver is to give some framing to these experiences. And so for me, I'm a former caregiver. So of the 10 profiles that are there, one of them is that you're done, right? That has a whole other set of issues that are associated with it. And most people unlatch from us at that time, right? And you would hope someone's grabbing back on, if it's loss that happened there or something else, that there's more to it. But there is a lot there. And who told us to add that? But the caregivers themselves. That was the one that had nothing to do with papers or academia. It was caregivers that said, you forgot one, and it's this one. And what we're doing now together with Duke, who have joined us in pouring over thousands of papers to come up with these. So these are analytical and first blush, is testing these. And we're bringing people from across the different care navigator groups, as you've likely have researched and seen. A lot of groups are here to try and help caregivers get services, to insurers, to community organizations, to other academics, to employers around the table to say, if you chose to look at the caregiver experience, what could we learn? And it was interesting. We are even seeing city planners start to use these 10 different profiles as they start to map out who is living in a zip code. What are they experiencing from that perspective? And are the services we provide actually located where they're needed? That is a dramatic first step. So back to social determinants, that's the step we need, right? Are we making these connections? So in going through, what's happening now in a very structural way, the profiles that are put forward, these caregiver profiles, are the thing that we believe is going to take us back to leapfrogging and a step change. It is the step change that's going to move us forward. Something as simple as just asking when someone's entering care and exiting care, who is the family caregiver, and then asking where are they at in this, will go a long way. Something as simple as adding something to the home care professional that comes in, 2 questions for the family caregiver who's there or not, about them and how they're doing. How can that change? their health. I'll end on this. CDC in August last year, 2024, released a paper, right? The MMWR, which is the bell. If you're from HIV, that's usually the first slide is when MMWR came out with there's a cancer spreading. This one, which was not HIV, was comparing family caregivers with non-caregivers on 19 health outcomes. 13 of the 19 are disproportionately worse if you're a family caregiver, which means the act of care in and of itself is a determinant of health. And it's it's making the caregiver less healthy while it's making the recipient more healthy. That dyad, that is the issue now. And we know that for the care workforce and haven't done much there yet. Right. Now, if we were an infectious disease, it has now spread to the general population, if you need to look at it that way, right? So all of these factors are because RCI brings this perspective into these other realms. Now it's that system's job to pick that information up and do something. And that's where things like the Office of Caregiver Health, like the different convenings that we offer, like bringing people together to test a new model, it starts to bring implementation action against just ringing the bell and having the conversation first.
Right, right. It got me thinking about a year and a half ago. I profiled this TechStars group, specifically focused on age tech, and Melinda French Gates and her venture capital firm were involved in this, and it was all about how we could speed up sort of the development of innovation and interesting technologies to support caregivers. I mean, I know we're not at the stage where we got robots all over the place or doing whatever sort of the future vision is for this, but what excites you in terms of some of these tools? I mean, obviously we can't entirely get rid of the human touch, and the human touch is oh so very important in this story, but are there tools and technologies that you're personally excited about per your own experience, but also in running organizations like at Medtronic that like, hey, this could be a very important tool in, as you're explaining, sort of bringing that dyad under control and balancing it off in some way?
Well, I think this is a really great question to bring caregivers together on, right? Because it's an excellent time. And I want to add that to your question, because what ends up happening, especially with the technology pathway and the innovation pathway, is that the family caregiver themselves is added in when it's time to execute, not when it's time to design. So that's my first reflection, is really pulling again from that same playbook of what RCI and many others do, which is first, if you don't see and you don't listen, you can't support. Right. So on this one, it's the same thing. We've got to be able to bring family caregivers together to be able to help in this process. Now, what I've seen as a caregiver and someone who is in healthcare, right? So I have the privilege of that connection. Is that, and I've said it often, we're all excited by Rosie the robot. Again, I'm dating myself by saying that. Until someone suggests she's the one that's going to bathe your mother.
Right.
So it isn't an afterthought to say, of course, human connection is important. It's the first thing. So how can technology and how can different ways of us processing information help us amplify that opportunity for connection versus replace for something that we really didn't intend to replace? I'll include paid leave in it too, right? It wasn't intended so that we would be the community health worker at home. It was intended so we could come home when we need to, right? And when we decide. That's very, very different. So it is to slow our roll to make sure we pay attention. Ring was not created so that it would be inside the house to voyeur on things. It was created for security outside the house, right? So innovation involves, of course, adapting to what's needed today, but until we bring the conversation into it to really pressure test what really is needed. And that includes for the care recipient and the caregiver. My mom wanted me there with her, not just to bathe her, right? So all of that is really important. So what I'm seeing is exciting today, and I having just come back from the Home Care Innovation Forum, where this was being discussed deeply, is that the use of technology really in its rightful place to unlock time, so that time, which we can't regenerate, is used for the right purpose, so that whether it's a formal health worker, whether it's a family caregiver, our time is defined by what we're best suited to do, and that we're there to do it and to use that time with its greatest value. And so those things tend to be a lot of the backroom things. And especially with AI, to reimagine a future differently, not just to transform what already exists in the system. What is the new system when you're protecting for that time and that human connection? What would that look like? And that redesign is what's next, and that's what's necessary. But I can provide a simple example of AI. So let me go there. So when we come into a health facility or inside of the health system, we're often asked a lot of questions that are about us, right? In hospitals, it may be cultural, it may be religious, and it may be gender, it may be many, many things. It may be ethnicity as well. And if it goes down into something that is more structural, like religion or anything else, there are rituals and things that are important. And so I've used this example and actually changed the training protocol for a home agency. I said, my mom needs to take her first med of the day with breakfast. So her first meal of the day.
Right.
She's Hindu. She won't eat and based on ritual and belief until she's prayed. She can't pray until she's bathed, which means we need to wake up, get her bathed, make sure she's prayed so that she can have her first meal and take that med. You may see that she's non-compliant because she didn't take her first med till lunchtime in your world. And you may have assigned the first home health aide to come at 11 o'clock. In order for her to start her day, that meant her daughter had to not be on a Zoom call to make sure everything else got done so she could appropriately do what is appropriate for us. You could have known all of those things, or at least gotten closer to knowing those, the way the household works. And AI could have helped bring that to you and reshape the schedule so that, yes, someone may need to be here at 8 in. And none of it was about her compliance. It was about actually the system's compliance and not being compliant. Yeah. So that is a one example, very simplified, probably not the hippest and cool example or the sexiest example, but the unlocking time and putting it where it belongs when you're inside of the care space is the most important thing, including the time for discharge being as long as it is, and very little of it is about what a caregiver really needs. So how would you redo what is necessary for a social worker who is working so hard to get everything done so that people have what they need, so that their time is unlocked to really sit down with the family as it's time to come home? Those are two really big examples of what that may mean. We see, of course, the robotics that are involved in Walgreens now and getting prescriptions filled quickly, again, so the pharmacists can spend their time, right? Unlock the time. But also, it's not incremental on the edges. This is like the national emergency if a virus arrived. Ring the bell and rethink what it could be and realign to getting there. While, yes, getting some of the efficiencies along the way, but we're missing our opportunity if we only use technology just to get the current state more efficient. What else could we do? And we got to be able to do two things at the same time, is what I would say. So I hope that answers some of the questions.
Yeah. Yeah, no, again, I very much appreciate those examples. And again, thinking of, again, we don't need to focus it again on the, as you were saying, the Rosie the robot situation, when we have a lot of this other low hanging fruit that, can make a big difference. So I very much appreciate that. Paurvi, what else is coming up that we should know about as we're here in the middle of 2025 now, whether that's per the Rosalynn Carter Institute, whether it's some of your initiatives in terms of talks and lectures and other forums that you're going to be presenting in. Anything else we should know about while we have you today that I missed? Please take the floor.
You're very kind. Well, look, we're at a really exciting precipice of what our future will be. And we've announced it earlier this year together with the Carter Center. The work of the RCI and what we're doing with family caregiving is merging into the Carter Center at the end of June. And that's incredibly important and very, very intentional in that it offers the opportunity for us to embed this work, this process, and the visionary leadership of Mrs. Carter paired with President Carter. Mrs. Carter was a co-founder of the Carter Center as well. So it's bringing the power of all of this work inside of one entity that can, again, back to leapfrogging scale, right? Back to using your opportunities across so many different avenues, and bringing the best of what we know inside of that system for the next generation of what's needed. And so everything you've heard me talk about today is moving now into the Carter Center, and will be led from there in exploring expansion of that. And I purposely have put forward even the WHO resolutions that are there. We know the Carter Center has done a lot in the global space. And for every, and one of my team said this really very eloquently, for every family coping with river blindness, there's a family caregiver taking care of that, right? So these things come together, and we really are proud to be, it's bittersweet as the last CEO of the institute called the RCI. But it's also an honor to see this transition as we move there, and together with our team, and bring this data, this evidence, the body of work that has been there over time. We don't need to repeat things when things have been shown. So that's one really exciting opportunity for the caregiver space worldwide. Your questions have been astute about the U.S. and the rest of the world. This is everybody together, and we're putting ourselves in this work in that container now. And so that's important from the institutional view. What I see as I move on into my world again is financing has to change, and we're all seeing it in every realm. And I brought that up earlier here too, that this issue will not be solved incrementally and on the edges. We've got to rethink how we provide the resources that are necessary. We've got to rethink if someone is in your home taking care of the person, the primary person that needs care, it's probably not, it's way too complicated and yet so necessary to check on the person who's taking care of that person and make sure reimbursement's taking care of both of it, right? Like what would it take now if you started from the home and built out versus started from the clinic and built in? And that process is the community partnerships and the financing of them, and then re-architecting what that pathway looks like. It informally is already happening, but we don't need parallel. We don't need another, assisted living just for the Indian population, just for this population. How do we integrate so that the next time someone has a meal package sent home, it actually has what that family needs, right? That's another example of how technology, AI, and robotics could fix that problem quickly, right? Yep. All of that comes from taking time and being curious and bringing evidence to the storytelling versus the storytelling alone. So that's my final point. I think this unrequited need to be seen, which we all have, now comes with responsibility of the next decision that we're going to make. And the next decision is to sort through, and where I sit, to sort through how re-architecting financing and getting the flow to open again to those community organizations that are the ones that provide the support and are part of the referral pathway anyway. So how can we architect them now is necessary for this issue of care, so that families can then use the time that they need with their families. The final mile of care is being carried by each of us at home, and that needs to be looked at with every system that's involved in that final care mile. It wasn't intended to carry margin for another industry. It was to be there for the people that we're there for. So how to figure that out is where I'll be.
Awesome. It's an awesome message, an awesome story. Paurvi, really wishing you and your team the best with all of this as you progress through the rest of 2025, and hopefully things will sort themselves out in the Capitol, and we'll get these programs back to speed and at scale, as you say. And I look forward to, hopefully we'll do a follow-up episode next year. But really amazing work. Again, for everybody that is going to be listening to this episode across the various podcast networks, or who will be watching on the YouTube channel. Again, you've been spending time with Paurvi Bhatt, Interim CEO, Rosalynn Carter Institute for Caregivers, doing really amazing work, as they say, transform the systems change, improving the strength, health, and resilience of family caregivers. at scale. Paurvi, again, I want to thank you for taking the time out of your schedule to talk to us today for a little while about everything that's going on, your story. Thank you for everything you do. And as we like to say on our show, thanks for helping to create a better tomorrow for literally millions of people out there via what you're doing. Really great story.
Ira, thank you. Thank you for helping so many of us be seen. And I hope we can all kind of reflect on Mrs. Carter's quote about caregivers. We are all on an arc of caregiving, and it's important to note that and to take care of each other and ourselves. And if there's loss, that's also in our world, and most of us are experiencing some form of loss.
Oh, yeah.
To know that we're not alone in that too. So thank you. Thank you for the time.
Beautiful message, and I really appreciate you being with us today.
Thank you. Thank you, Ed.